From anatomy to anesthesiology, from pathology to pharmacology, from microbiology to medicine, a one-man resource to the world of health sciences. Welcome to Dr. Paul's Medical Lectures. A practicing physician, Dr. Paul offers you essential insights on diseases afflicting millions of people around the world. For today's lecture, here is Dr. Paul.
Today I want to talk a few minutes about male hypogonadism. Many people come to me and ask me, what should I do about this problem? You see, folks, we need to understand that hypothalamic pituitary testicular axis in order to understand this problem. So here it is, hypogonadism. What are the causes? How do you manage this? There are two types of hypogonadism, primary and secondary. First, I will give you some basic points about the primary hypogonadism and secondary hypogonadism. Then we will deal with the effects of testosterone on human body. So basically, hypogonadism in a male, it refers to a decrease in one or both of the major functions of the testis, sperm production or testosterone production. These abnormalities can result from disease of the testis, that is primary hypogonadism, or disease of the hypothalamus or pituitary, that is called secondary hypogonadism. The distinction between these two disorders, remember that. You can know the distinction by measuring the serum concentration of luteinizing hormone and follicle stimulating hormone. So basically LH and FSH helps you to distinguish between primary and secondary hypogonadism. The patient has primary hypogonadism if the serum testosterone concentration and or the serum count are below normal, and the serum LH and or FSH concentrations are above normal. The patient has secondary hypogonadism if the serum testosterone concentration and or the serum count, the sperm count are below normal, and the serum LH and FSH concentrations are normal or low. So in primary hypogonadism, spermatogenesis tends to be impaired to a greater degree than Leydig cell function, at least in the early stages. Spermatogenesis cannot be increased in men with primary hypogonadism because of damage to the seminiferous tubules. However, successful pregnancies have now been reported with men with primary hypogonadism, including men with Klinefelter syndrome. Using sperm, if you extract the sperm from testis and then you do in vitro fertilization by intracytoplasmic sperm injection, you can help people with infertility. In contrast, men with secondary hypogonadism can often have spermatogenesis restored with gonadotropin therapy or pulsatile gonadotropin releasing hormone GnRH therapy if pituitary function is normal and the patient has access to a center that provides this therapy. So basically, it's very common sense. It is primary hypogonadism and secondary hypogonadism. Primary, if the problem is in the testis. If the problem is in the testis, unfortunately, there is not much to do about it. But if the testis is good and if the problem is in the pituitary, then there is a much higher chance to help. All you have to do is to send some gonadotropins to stimulate this testis to produce more sperm. You see, if you think anatomically, it is easy to understand this concept. Now, the clinical features of male hypogonadism, they depend on age of onset, severity, and deficiency of testosterone. And how is the function, the sperm production and the testosterone production. And there are many different manifestations of testosterone deficiency. And also the time of onset. You should obtain different milestones of sexual development. Did the boy reach these milestones at appropriate age? If this person is not reaching, then there is a problem. Even in the pregnancy, in the first trimester, if there is ambiguous genitalia in a male at birth, that indicates testosterone production deficiency. A complete lack of testosterone production or androgen action during the period, it results in female external genitalia. Incomplete testosterone deficiency or androgen action causes partial virilization, ranging from posterior labioscrotal fusion and micropenis when the deficiency is severe. So, if the deficiency of testosterone is severe, then there is no way for the development of penis. In the third trimester, a history of micropenis, that is a very, very common sign of testosterone deficiency. So, it starts with physical examination. Then in puberty and pre-puberty, when the onset of testosterone deficiency occurs at any time after birth, then you need to see what is happening. Then in the adults, when testosterone deficiency occurs in an adult, there will be decrease in energy and libido. And many times people lose their hair, the body mass, the bone mineral density. So these symptoms, if you see them in an adult male, you have to act. Because testosterone affects many tissues. Lack of testosterone can cause many different symptoms. In adults, the symptoms are likely to be worse if the hypogonadism develops over the course of weeks or months than slowly over years. Adolescents and young adults who have not yet completed puberty appear younger than the chronological age. They may also present with small genitalia, difficulty gaining muscle mass in spite of vigorous exercise, lack of a beard, and failure of the voice to deepen. In adult men, several common but non-specific symptoms appear. Decreased vigor and decreased libido, depressed mood, decreased muscle mass and body hair, and hot flashes. Yes, hot flashes can happen even in men. Gynecomastia can happen. So that breast formation happens with testosterone deficiency. So when you see gynecomastia, you need to test these people for any deficiency of testosterone. So I just wanted to give you a brief introduction to this point, and I'm going to talk about this topic more in the coming weeks. So we will have a discussion.